So I'm going to say welcome to the second part of the introduction, because as I was actually thinking about it, I realized there's quite a few more things I think are very interesting about medications. Certainly a lot of questions I get from patients about why we're using one medication versus another, or why we're using something like a capsule versus a tablet. And I thought those are things would be worth exploring a little bit before we got into the individual medicines and the individual illnesses that they treat. So one of the things I want to talk about briefly is I'd like us to go over how we get medicines into us in the first place, because that's a really important topic, how those medicines come out of us, another very interesting topic, and the risks and benefits of medicine, something we think a lot about when it comes to prescribing medications, as well as, the general philosophy that we sometimes take when it comes to medications or not to medicate. Sometimes people end up on way too many. Some people are not on enough. And I think it's worth thinking about that because they're all subtle but interesting questions, and ones that you might come across as you're working with patients yourself, or even in your own life or your family's lives. So the first thing I'd like to do is let's talk about administration, getting it in, because basically you got to get the medication in if it's going to work. Interesting little side note. One of the reasons why medications fail to work most of the time is we're not taking them. And that's actually a very common thing. So it's something for always to be thinking about, whether you're a parent with kids who are supposed to be on medications, whether you're a clinician, a therapist whose patients are supposed to be on medications, or a doctor whose patients are supposed to be on medications. They don't work if you don't take them. And the reality is there's a lot of reasons why patients won't tell us that. A lot of it's just embarrassment. A lot of it's they just don't want to be confrontational. They feel like you'll be disappointed in them. So I always try to lay that out at the beginning that, these medicines are your medicines. You're taking these medicines for you, not for me. And if there's a reason I want you to take them, I'll tell you what it is. And if there's a reason you don't want to take it, you tell me. Sometimes I feel like the used car salesman of medicines is really funny, because I'll be sitting there going like, what's it going to take for me to put you in this medication? I'll write down a medication on my list and you write one on yours, and we'll hand them back and forth and say, I'm not going to do a benzodiazepine. How about an SSRI? No, let's try. It's not exactly like that, but it certainly feels like that a lot of times. And that's reasonable. We're trying to get people to be comfortable with what they're doing, and there's good reasons why they're not. So let's talk quickly about different ways of getting medicines into our body. The most common way, of course, is through the mouth, right? We've got capsules, tablets, and liquids. And the reality is capsules and tablets, mostly similar. The capsule, of course, is the ones that look like they're like in little plastic capsules, right? And the tablets are the ones like aspirin that usually they could be coated, but they just look like a little pill. Sometimes they have a score in them. That means that they can be cut into smaller doses, which is sometimes useful. But some of them are coated for the purposes of slowing down absorption, like a time release, or maybe just getting it through the stomach without causing nausea, like aspirin that has a coating on it to keep you from getting upset stomach. Those we don't want to cut, because those are the ones that you'll bypass the coating. Capsules, similarly, some of them can be opened and they have a powder inside, and that powder can be put onto a cracker with jam for kids who can't take pills. Other capsules, we don't want them open because they may be a time release capsule, and that may be that opening it will cause that to go into the body too quickly. Or some of them are a combination. They have beads in them. A lot of our stimulants have these little beads in them that are little time release beads. You can open up those capsules, put them into things, and the beads still work. They still have a time release aspect to them. But it's really important to double check that with the prescriber, because once again, there's certain reasons why we're using certain things. And liquid, of course, is almost always for those people who can't swallow pills. And an interesting story, apparently liquid SSRI medications like Prozac and Zoloft and Celexa taste really horrible. And as a matter of fact, they taste so bad that I've had plenty of kids who've learned to take tablets or capsules just so they don't have to have the liquid. But it's available, and I use it quite often. It also allows me to do really small microdosing when I want to go really small and start low and go slow. So you can certainly see liquid formulations of many medications. Lots of my medications come in liquid. Abilify comes in liquid. We'll be talking more about that in the future. The other way that we get it in through our mouth is sublingually, and there's a lot of times it's a little tablet some people have seen them in B12. We have a lot of medicines in the hospital that we can give somebody sublingually, put it under the tongue, it just melts immediately, and it goes right into the bloodstream because there's a lot of blood vessels under the tongue. So a certain amount gets swallowed, but a lot of it goes right into the body directly. That's incredibly helpful when we're not sure if a patient is taking medication, because we can put it sublingually, it disappears immediately, and pretty much know that that medicine's gotten into the system. It's not quite as quick as giving it as a shot, but it's pretty fast and pretty effective overall. The other way that we do this is through the nose. And if you think about it, we all know about the illicit drugs of abuse, people snorting cocaine or snorting heroin. Why do they do that? Well, turns out for the same reason that you can get a very bad bloody nose very easily. The nose, designed to warm up the air as we breathe it in, is just filled with blood vessels. And they're very, very, very close to the surface of the skin. That's why it's so easy to get a bloody nose. It's also why if you put a medicine in the nose, either as a spray or as a powder, then it gets absorbed very quickly into the bloodstream. Once again, almost as quickly as if you give it in a shot. And there are medicines that we use that way. Ketamine, which we use for treatment-resistant depression, something we'll mention later on, it actually comes in a spray now. And that's pretty interesting. Instead of having to put it in an IV or in the blood, we can go in through the nose. Much less invasive and actually works just as well. So that's kind of an interesting direction where we're going with certain medications. Another way that you can get medication is through the skin. And so we have a lot of patches. There are creams and patches. Most people are aware of patches for smoking, like to quit smoking. And those are nicotine patches. They actually give you a little bit of nicotine slowly through the skin that's absorbed so you don't have the craving for cigarettes. We also have Daytrana and a few other patches that are for attention deficit hyperactivity disorder. We actually can give stimulants through patches, and that allows them to act over a longer period of time, maybe a little bit more gentle as it's absorbed. Downside, it can actually cause rashes, so we actually have to have people move the patch around to different places. But it's still a very decent way to give medications. Now, there's of course through the skin methods, and by that I mean a needle usually. So we have injections, and injections there's two forms that we normally talk about. There's more, but the two that we talk about most are the ones that go into a vein, IV, which stands for intravenous, right? Goes into a vein. That's where they usually start an IV on you, and then they can just put the medicine right into your blood. That's the fastest way. It circulates very quickly, and it gets into your body about the fastest way you can do it. It's also the most powerful way of getting it. It's why people, when they inject illicit drugs like heroin, that is just the fastest, most intense way to get it into the system. It's also one of the most dangerous for multiple reasons, because for one, you're putting something right into a place that's not supposed to have a lot of stuff going into it. Something else we can talk about at some future date. Intramuscular is very interesting and actually very important for us in psychiatry, because we are now giving a lot of long-acting medicines through the intramuscular route, which means we inject into a muscle, a big muscle, the arm, the gluteus maximus, i.e. the buttocks, into your thigh. We inject a medicine that is contained in basically a blob of oil. And what that oil does is it prevents the medicine from coming out immediately and just going right into your blood system. It allows it to leach out, basically come out very slowly in a controlled manner. These injections can last a week or even a month. And so these long-acting injectables can be great for people who have a hard time remembering to take their pills, or they're just kind of really struggling with organization. And so we're finding these medicines to be extremely helpful in psychiatry. And I would expect we'll see more of those coming out. You can also breathe in medications. People are a little bit confused about that, but when you think about it, that's exactly what happens when you go to surgery, and they put the mask on you and they say breathe and count back to 10, and you usually make it to 9. That's because you're basically breathing in an anesthetic, which is immediately absorbed through the lungs, much like it is through the nose, right into the bloodstream. Very fast and effective way of getting medicines. Or poisons, which is why there are toxic gases. And then finally, the way that nobody really wants to talk about, but one which is viable, is rectally. And that, of course, is if we have a patient who is having a seizure and we just can't get any, what we would call access. We can't get to a vein. We don't want to put anything in their mouth because, they're seizing and we don't want them to choke or anything like that. We can actually deliver a medication right up through the rectum. And it works the same way as the nose. Lots of blood vessels, and it gets absorbed quite quickly. not a common way we tend to go in psychiatry if we can help it. So we've talked about getting medicines in, and I think it's important for you to kind of have that concept because, once again, they come in a lot of different forms. Meds also have to get out of the system. This is basically how we don't build up meds to a point of getting sick or toxic on them. It also goes back to what I talked about in the last episode, Halflife. Halflife, which, as you remember, was about the time it takes for a medicine that's in your system now to reach half its original level. So as it comes out of your body, it's going down, down, down. When it reaches half, that's half-life. That's how long it takes. So a short half-life means it comes out of your body very quickly. A long half-life means that it takes much longer time to come out of your body. And those are long-acting medicines. We'll talk some details about those in the future. But what determines half-life is things like how your body gets rid of the medicine. Alcohol has a relatively short half-life because it's actually able to come out of the body in many ways. One of the ways it comes out is through your lungs. If you think about it, when you run into somebody who's been drinking, you're like, whoa, dude. Or the police officer pulls out the breathalyzer and says, breathe into this, and I want to see how much alcohol you have in your blood. And then you might ask the question, huh? It's because the alcohol is going from your blood into your lungs, just like oxygen's going from your lungs into your blood. That's what breathing is. Alcohol in your blood will go right into the air of the lungs. Alcohol is also processed by the liver, and then it's excreted through your urine. So that's something I want to mention. The liver's a super important organ when it comes to medications. The liver is your chemical factory. It is what takes one thing and clicks it onto another. It takes one molecule and turns it into another through enzymes and all of these things. Also why everybody's different, which I'm going to talk about in a second. But the reality is the liver is such an important organ because it, first of all, maybe it takes something like alcohol and breaks it down into something that the body can then get rid of, which alcohol itself can go out through breathing out, but then it's broken down into other things which the kidneys can then filter, and it goes out as pee, which is one of the reasons why you have to urinate so much when you drink a lot. You know, people say you don't get a lot of fluid from alcohol. It's a diuretic. You've probably heard that, meaning you actually lose more liquid than you get. That's because your body's trying to get rid of it. Your body's going, all right, liver, break it down, good. Kidneys, let's get that stuff and take it and get rid of it. That's how that does. It's also why alcohol over a long period of time equals liver disease, because your liver is so busy trying to detoxify this stuff, get rid of it. It's also true why Tylenol is so dangerous, because Tylenol, if you take it in really high doses, really, really taxes the liver, which is trying to make it into a product that it can get rid of. And if you put too much on the liver, it overwhelms the liver. So that's why it's liver toxic. The kidneys are super important because they're our filtering system. All your blood goes through the kidneys in a fairly short period of time. And what happens is the kidneys are like little filters, and they take things that shouldn't be there and they get rid of them. So a lot of drugs that you take are gotten rid of through the kidneys. It's also why we have to be careful when we give you more than one medication. Some of them compete, we call it. They all want to use the kidney to get out of your body, and if you put too many of the same kind of medications, they build up too quickly. So that's how you get things like medication interactions, where they're competing, they're trying to get in or out the same way, mostly out. And that affects how long they stay in the system. It's a very important thing for us to keep in mind. And then, of course, you know, we always have to worry about things like mothers who are breastfeeding, because medicines can also come out through the breast milk. And, you know, most of the time they're small amounts, and most of the time, or in most cases where we say they're safe in breastfeeding, they don't cause problems in the amounts that they come out. But it's very important for us to keep that in mind. Now, I mentioned something about the liver. I said the liver is the chemical factory of the human body. Everybody's liver is different in that your genetics, your genes, basically determine which chemical compounds your liver makes and in what quantities. Everybody makes different combinations and slightly different ones. So one person makes a compound that breaks down Zoloft very quickly. Bam, just eats it up. That person is what we call a fast metabolizer, and they can really chew Zoloft up. So they could take a lot of Zoloft and it wouldn't build up in their system very well. Another person has a different enzyme that breaks down Prozac very fast, but doesn't break down Zoloft very well. So you give them Zoloft and just a little bit builds up really fast, and maybe they have a side effect and they don't have any benefit. It gets really complicated, but this is why one person's body will act in one way to a medicine and another way to a different medicine, when somebody else could be just the opposite. This is why we have to work on trying to find the right medicine for the right individual. It's really frustrating, and a lot of people feel like human guinea pigs. I hear it all the time. My patients are like, I'm tired of being an experiment. But the reality is, at this point in time, proof is in the pudding. We know if a medicine's helping you or giving you a side effect once we give it to you. But the liver's complicated, and it's doing its own thing. There is a really interesting future coming, and we're actually almost there, and some practitioners are using it quite well. The genomic, they're using genomic medicine, which means they take some of your genes, like a swab from the cheek, and they send it off to a lab, and they break down your genes, basically. They sequence your genes and look at them, and they say, this person makes this enzyme, and this other person makes this enzyme. That means they'd probably be better on this medicine than that medicine, and they might have a side effect if they take that medicine and this medicine. Soon, I think that's going to be the rule. We will get this test. We'll say, this is a Zoloft person, this is a Prozac person, this is an Abilify person, this is a Risperidone person, this is a lithium person, this is a Lamictal person. And all of those names I will be talking about in detail later. But right now, it's still kind of a new science. We're really in the beginnings of that world. But I love the idea of being able to do a cheek swab, send it off, get back a list of all the meds that might be effective in a particular patient. And we are definitely getting there. So I want to talk for a minute about risk versus benefit. It's an important question. Medicines all have certain risks. Even aspirin, even very benign medicines that are over the counter have risks. And if you ever pull out the list of side effects, it can be quite daunting. Like hundreds of things on it. It freaks people out. They'll bring these lists in and I'm like, yeah, but the only top 3 are the ones that hardly ever happen. And those are even pretty uncommon. That's okay. That's why we go to med school. We go there so we can learn these risks and what they mean. The element is that every medicine still has potential risks. So why would we use them? Why would we give our kids or our loved ones or ourselves medicines when we look at that list and say, oh my gosh, that's kind of scary? It's because there's also benefits. And if the benefits outweigh the risks, then that's the equation we think about. And, I've said it before in another video, but, exercise has its risks. Exercise has its risks because you can sprain your ankle, you can break your leg, you can fall, you can have a heart attack if you over-exercise, all these things. But it also has great benefits. We try to minimize the risk by maximizing the benefits. Well, medicine's the same way. And, the example I like to say is chemotherapeutic medications, which have a lot of side effects. We all know some of those. Losing our hair, feeling really, really sick. They're toxic, actually, but they're more toxic to cancer cells than they are to us. So we take the risk of getting very sick in order to try and prevent that risk of dying from cancer. So we have to look at the risk and the benefit. In that case, it's pretty intense. But at the end of the day, it has to be better than not being on the medication. And I can make those arguments, and that's what I will be talking to my patients about. Why do I want to risk the black box warning for potential to increase suicidal thinking in young people by putting them on a medicine when they're depressed that will help their depression and so on and so forth? It's because the benefit is much better, much greater than the risk, and that's why I would do it. Sometimes side effects aren't even always bad. We have some medicines that we actually use for their side effects because they weren't very good at the other thing they did. So a good example is trazodone, which is a very common medicine used in psychiatry for sleep. And it actually is an antidepressant, and it works pretty well as an antidepressant, except for the people are so sleepy when they take it, they can hardly tolerate the medicine at its antidepressant dose. By the time you get there, they're really, really tired. Well, we decided, we can use it in small doses, and they still get really tired, and maybe they'll get a little antidepressant effect, but we actually use it for its side effect, not its original indication. But most side effects are things we try to avoid. Sometimes we can't, and we just decide whether it's worth it or not. The next thing, and this is something I want to kind of talk about because it's important, and you're going to see it whether you're a family member, whether you're a patient, whether you are a practicing clinician, whether you are a social worker or a therapist. Polypharmacy. We see patients with lots and lots of medications. A lot of times, there's good reason for it. If you've got blood pressure, uncontrolled blood pressure, sometimes it takes 2 or 3 agents for you to really get that blood pressure under control. And if that's what it takes, that's what it takes. Unfortunately, especially in psychiatry, we have patients who are really, really ill, And we often will try one medication and they'll feel a little bit better, like say a little less depressed, but not enough. And then they get side effects. So we want to keep that medication because they're getting some benefit, but let's try and add another medication. So we add another medication. Now they're feeling even better, a little more side effects, but they are feeling better, but still not quite there. So we finally add this third medication and all of a sudden they're doing really, really well. This is great. We've got all these side effects, but we're doing really well. And the question is, was it the third medicine that's the medicine that's working for them? Was it the combination of the second and the third medicine? Was it the combination of the first, second, and third medicine? And we never know for sure. But when I see people with a lot of medicines, especially when they are duplicates of the same kind of medicine, like 2 antidepressants, 2 mood stabilizers, 2 antipsychotics, I will often say, maybe we want to try and clean this medication regimen up. Let's take old medicines off and see what happens. What's the risk? The person could go back to feeling the way they did before, and that's a pretty scary risk for a lot of people. What's the benefit? Less medication, less side effect. So we have to kind of weigh that and think about it. And it's one of the it's one of the trickier elements to what I do, honestly. We'll talk about when combinations make sense. We'll talk a little bit about when they don't as we get into the individual illnesses, because that's where you're going to start seeing these things. Lastly, I want to talk real quickly about why we don't like people stopping their medications right away. It seems obvious, but it's not necessarily. It's not addiction, and people will use that term. They'll say, I'm addicted to my SSRI because every time I stop, I feel like garbage. And the reality is, you're not addicted to it. You don't crave it. You don't go out in the street seeking it. It's not something you want to take again when you stop. It's something that your body has developed a dependence on, or your body simply may need it to be doing better. And when we stop, then whatever it was we were treating, our depression or anxiety comes back. It doesn't mean that the depression or the anxiety was caused by stopping the medication. It means the medication was treating it, and now it's not. But there are some medications, especially those with short half-lives, that tend to come out of the body very quickly, that the body can have discontinuation syndrome from, where if you stop it abruptly, you feel like garbage. That happens with the short-acting SSRIs. It can certainly happen with a lot of other medications. And then with benzodiazepines and stimulants, you can actually develop more of a dependency where you really do feel that kind of almost a withdrawal or feel very sick on stopping when you stop taking them suddenly. Well, I know that was a lot of stuff, and that's why it was sort of a second introduction. Moving forward, I plan on doing one program just on SSRI medications because they are the Swiss Army knife of medications, and they're used in so many different illnesses that I kind of want to talk about them on their own. But after that, we'll jump into depression, obsessive compulsive disorder, anxiety disorder, attention deficit hyperactivity disorder, bipolar disorder, mood disorders, and we'll talk about what you might see in those populations so you have a kind of broad vision of meds and how we use them. Hopefully this is interesting. It's all stuff you didn't even know you wanted to know, right?